Hi everyone. Today we'll be dealing with a small topic of behavior management, that is communication and behavior shaping. Now, behavior management is important in pediatric dentistry as we are dealing with different age group children. So, in order to attain a positive dental attitude in the patient, as well as for our treatment to be successful, we need a positive behavior from each child, whomever we are treating. So this is very important part. And in terms of your exam point of view, this can come as a long essay as well as short note. Now moving on to the definition of behavior management. So it is defined as the means. Wright has given the definition in 1975 as the means by which the dental health team effectively and efficiently performs a dental treatment and thereby instilling a positive dental attitude in each patients. So there's something known as behavior modification. It is defined as the attempt to alter the human behavior and emotion in a beneficial way and in accordance with the laws of learning. Now, behavior management techniques can be classified according to this thing. The classification can be done into non-pharmacological as well as pharmacological behavior management. The first resort of behavior management is a non-pharmacological behavior management, where we have various techniques employed in order to shape the behavior of the child. And the last resort of behavior management is a pharmacological behavior management. Now we'll go for the classification of non-pharmacological behavior management method, where it is broadly classified into three categories, that is communication, behavior shaping, and behavior management. Communication can again be further subdivided into verbal, non-verbal, and combination of verbal and non-verbal. Now, behavior shaping, that is, we are modifying the behavior of the child. So, under behavior shaping, we have desensitization, modeling, then contingency management. And under behavior management, we have audio analgesia or white noise, biofeedback, voice control, hypnosis, humor, coping, relaxation, implosion therapy, and aversive conditioning. Now coming to the first part of the classification of non-pharmacological behavior management, that is communication. So this is the first resort of behavior management where we have to communicate with the patient. So communication can be either, as I've told earlier, it can be in the form of verbal, non-verbal, or combination. So this is a universal type of behavior management which is employed in both cooperative as well as uncooperative child. So it's a fundamental form of behavior management, and it helps to establish a relationship with the child which may allow a successful completion of the dental treatment. And it also helps to, as I told earlier, it also helps to develop a positive dental attitude. And it should establish communication from the first entry into the reception area. We have to start communicating with the patient right from the reception area. Now, types of communication, verbal, non-verbal. Verbal is by speech, how you talk, okay, by calling out their names or their pet names, all those things. And non-verbal, what we do is by smiling and maintaining an eye contact with the patient, then showing concerns, patting, giving a hug, shaking hands, all these comes under non-verbal. And combination is both verbal and non-verbal, where we talk to the patient and we shook hands and greet them as they enter the reception area. So communication, it should be comfortable and relaxed, and should be complimenting also. If we get a positive behavior from the child, we should always compliment the child by saying, oh, very good, like that. Okay. And usually it's effective in younger children more than 3 years of age. And communication should be from a single source. Communication at the eye level is also very important to achieve a friendly atmosphere. And it's a multisensory process which includes a transmitter, that is a dentist, then spoken word, and a pediatric patient, the receiver, who we are talking to. Now, there are some word substitutes we use in our practice. They are known as euphemisms because most of the dental term they won't be able to they won't be able to grasp. So word substitutes are given. They are known as euphemisms. So these are the substitute words which can be used in presence of children. It's very important while addressing the child. So for example, we refer rubber dam as raincoat, radiograph as tooth picture, then like that. So these are the various things. So tooth bug, okay, the bacteria which causes, then rubber dam as raincoat, okay, and topical fluoride gel as cavity fighter. So these are the euphemisms we commonly use in our daily practice. Now the second option after communication is the behavior shaping. We are shaping the behavior of the child unless a desired behavior is attained in the child so that we can carry out a treatment. So definition, it is a procedure which slowly develops behavior by reinforcing a successive approximation of the desired behavior until the desired behavior comes into being. So it's a step-by-step procedure to make the child involved in the treatment. So it's necessary to make all explanation to the child, like whatever we are doing at his level of understanding by, as I've told, by appropriate use of euphemisms. Now, the first method of behavior shaping is desensitization, and it was introduced by Joseph Wolpe in 1975. So it is accomplished by teaching the child a combating response, such as relaxation, and then introducing progressively more threatening stimuli. So if a patient comes, we will be starting with a less threatening stimuli, and then over subsequent visits, we will be just introducing each one. So this is an effective method for reducing the maladaptive behavior. So under desensitization, one more technique is tell, show, do technique, which commonly we say as TSD, tell, show, do. So it was introduced by Adelston in 1959. And here what we do is we tell the patient what we are doing. Each step we just tell the patient what we are doing, we explain it, and then we show it. Okay, we show it in either in a model or in the some other models, and then after that we do the procedure. So that's why it's known as tell, show, do technique. Now, indications of tell, show, do technique is usually we employ it in during child's first dental visit because he's new to our environment. So he don't know what is a mouth mirror, what is a probe, he don't know what is the aorta. So we just show him what it is, and then we first tell him, then show, and then we go for the treatment. So it's very effective in case of child's first dental visit. Then in cases of subsequent visits where we are going to do a new dental procedure, because during the first visit you will be doing a dental, this is oral prophylaxis. Later, if you want to go for a cavity cutting, we'll have to introduce the aorta. So it's subsequent visits where you're doing a new dental procedure, it's very effective. Then also in fearful child, because the child will be coming to you and he will be having some subjective symptoms from his parents, his friends, that dentistry is something to be feared. So those fearful child, we have to go for a TSD technique so that we can just show them what it is and what we are doing. Then apprehensive child, same thing, because of information received from parents or peers. So this is the desensitization. In this picture, you can see that a doctor is explaining what it is. So normally we say as a camera for taking the picture of a tooth. As X-ray unit, we refer to as camera. So here you can see the desensitization method carried out. And this is tell, show, do. Here in the picture, you can see that the dentist is showing what it is. Okay, and the child is able to feel it. And then he's showing it in his hands, how it performs. And then later, once the child is adjusted, then we start performing the treatment. It's very effective method. Now, second method of desensitization is a modeling. It was introduced by Bandura in 1969 and is based on social learning principle. So here we actively involve the patient to observe one or more individuals, models. It can be a live model or another model where we demonstrate what we are doing and to get a positive behavior. Now it is done by live models. So live models can be the patient's own siblings, elder sibling, where we make the patient's elder sibling to sit and then we perform some treatment so that he can watch what it is. Then either or the parents of the child. Then film models can be used, or posters or audio visual aids like video, all those things. So in this picture, you can see that a child viewing his elder sibling's treatment. Now, contingency management is another method of desensitization where we modify the behavior by presenting or withdrawing something, some reinforcers. So positive reinforcers one whose contingent presentation increases the frequency of behavior. So if a patient if the behavior of the child is good, so we reinforce that behavior by providing him something which he likes. And negative reinforcer is something which we whose contingent withdrawal increase the frequency of behavior. So sometimes what we do is we ask the mother to just move away from the patient so that we can do the treatment. Now, types of positive reinforcement include social, material, and activity reinforcers. And social, in case like we praise the child, then we smiling gesture, then shaking hands, patting, telling them very good, like that. So that becomes a social positive reinforcer. Material in the form of toys or involving in games with the child. Then activity reinforcers, again, watching a TV show with him, all those. So these are the positive reinforcers. So these were the topic just regarding the non-pharmacological, the first two method, that is communication and behavior shaping. So these two topics are very, very important. Thank you.